So welcome everybody to our workshop on the impact of stigma and discrimination on people who use substances in Leeds, Grenville and Lanark. My name is Jennifer Adams. I am the harm reduction coordinator at the Lanark, Leeds and Grenville Health Unit, and I'm privileged to be here with Jess Bashir, and I will let her introduce herself, who is someone who has worked on this project right from the beginning with us.
Hi, everybody. My name is Jess Bashir. I have lived experience with opioid use and other substances and was lucky enough to be one of the peers hired on with this project. Fantastic.
So we recognize today that this topic that we're going to discuss can be and may be triggering for some. We welcome you to leave or to take a break at any point along the way. If you're needing to speak with someone, please reach out to a trusted friend, a colleague, or your own manager. We encourage this space to be safe and non-judgmental and a respectful venue, and we encourage everyone to lean into discomfort that may come from the topics that we're going to discuss today. We hope that you'll share openly, honestly, and speak your truth. The purpose of this workshop is not to place blame or shame, but to foster self-reflection, personal and professional and organizational discovery and growth. I will hand it over to Jess to do our land acknowledgement.
Thanks, Jen. So we would like to acknowledge that the sacred land on which the Leeds, Grenville and Lanark District Health Units, Rockville specifically location is located on. It has been a site of human activity for over 15,000 years. The land is the Mohawk territory of the Haudenosaunee, the Haudenosaunee people, and the unceded traditional Algonquin territory of the Anishinaabe people. This is covered by the Crawford Purchase Treaty from 1783. I would also like to recognize that the Indigenous people have and continue to face higher rates of violence, death, and incarceration than non-Indigenous people. At the same time, Indigenous people are resilient and resourceful. As we discuss the topic of substance use and the impacts of opioid poisonings, we will reflect on the many complex, intersectional, current, and historical drivers of the opioid poisonings and the stigma that people face around them, many of which disproportionately impact Indigenous people.
Thanks, Jess. I will take this opportunity to acknowledge that I come to this work from a place of privilege and power. I also recognize that privilege and power is unequally distributed in society and further creates health inequities for people who do not hold the same. Privilege is an unearned benefit and opportunity or advantage that someone has because of one or more facets of their identity, including their race, religion, gender, sexuality, class or wealth, or ability. Holding privilege often results in having access to opportunities and power, while not holding privilege can result in experiencing discrimination and stigma and having limited access to power. I commit to striving to use my unearned privilege and power to be a good ally to work towards creating more equitable and safer access for those who do not hold the same. Jess, I believe that you wanted to do another acknowledgement as well.
Thanks, Jen. So we would just like to recognize that we have lost a number of lives in our community over the past few years. Many, if not all of which voices were part of this survey and some of the voices you may be hearing about today. This toxic drug supply that people have access to right now is ruining people's lives. It's tearing families apart. People are being incarcerated. It's something that nobody had asked for and is something that as a society, we need to strive to continue to work towards changing.
Thanks, Jess. So we're going to explore today, we'll talk a little bit about the program grant in which this work was completed under. We're going to explore some stigma and discrimination, also the driving forces and the impacts of stigma. And then we're going to look at an action framework that's been developed by Public Health Agency of Canada and explore interventions that we can do within our own community. We definitely recognize that there will be some time for some self-reflection. And also we encourage people to do this training with your colleagues and or others within the community to further the conversation around what we can be doing as a group to address some of these inequities that are happening. So the very first video we want to share with you today is a video that was produced by the Mental Health Commission of Canada. This video features Jess and Melinda. Jess is a community harm reduction support navigator and peer support worker with over 25 years of lived experience with opioid use. Melinda is a primary healthcare nurse practitioner with years of experience supporting people who use substances. And in this video, Jess and Melinda explore the stigma often experienced by people who use opioids and other substances when accessing health services and what direct health service providers can do to reduce and improve the quality of care that people who use substances receive. This video is fantastic because it features not only Jess and Melinda, but their local healthcare and people that live in our community in Leeds, Grenville and Lanark, and share their experience of what they've witnessed, what they've experienced themselves within Leeds and Grenville.
Today, Canada's opioid crisis is worse than ever before. Today, 20 people will die of overdoses. 19 of them will be accidental. Today, we can choose to listen. We can choose to do something. Today, we are introducing you to Jess. Jess is a person. She is also a mom. She has a great career and she loves playing basketball. Jess is also a person who uses opioids.
You know, I grew up, I had a great family, a great mom. I was loved as a kid. I was pretty athletic and into sports. That was kind of what kept me going. And when I was 15 years old, I had a major injury. Wasn't able to play sports anymore, which really took away a lot from my life. But at the same time was given a giant script of opiates to control the pain. It controlled the pain, it took care of the loneliness, and it made me feel great as a person. So that was about 25 years ago. I've had a lot of different avenues. I've had a lot of different experiences. I've experienced drug use as somebody in a privileged position, and I've spent a lot of time on the other side being treated really poorly, really badly, and I think that stuff just kind of sunk in, and I began to see myself as that person. I didn't feel deserving of care. I didn't feel deserving of anything, really. I felt like I was using people's time, that I had made the choice to be this person. It was my own fault, and that's not true.
Opioids are accessible in our communities, whether we admit it or not.
It's not like my parents had to keep it in a lockbox or whatever. I just had, like, you know, these bottles of morphine that I just could take whenever I want, and there was so many. So I really, there was no stigma. It was just a normal thing, really. It was just normal behavior. And even when that script ran out, everybody else around me also had loads of opiates in their medicine cabinet. They were everywhere. So I didn't have to worry about being sick or having to find a dealer or something else. You know, I was okay. I was good to go. It wasn't until I started using chaotically and that my use became like very apparent to people that the stigma started really kicking in. And that's because people could tell just by looking at me what I was doing. You know, I wasn't able to hide it anymore.
For people who use substances, seeking much needed help is never easy.
Feeling, you know, the dirty looks, even just from people that have no idea who I am. Going into the hospital, going into the pharmacy, even going into work. You know, I just always felt like, and I'm sure that they were saying, there's the addict. Here comes the crackhead, you know, using all sorts of inappropriate language. but it was what it was, and the farther into my use and the heavier it got and the worse my life got, the more stigma started to affect it. And, even to the point that I couldn't rent a hotel room regardless of how much money I had. Cops would stop me whether I was doing anything wrong or not. There were places where I was not welcome to. My Facebook account, got shut down. There was just many different little things, and they all just kind of added up to the whole world thinks you are less than everybody else and you need to stay down in the dirt where you belong. And it's not a nice feeling. It really is not a nice feeling to have.
Help is not available when education is lacking.
So I think really what stood out, the most and was a common theme was the lack of knowledge, regardless where I went. Nobody seemed to know what to do to help, and they all wanted to give more pills, like let's give you this, and this, maybe benzodiazepines will help, and you need to go to treatment because that's the only way you're going to get better. So I think even saying that you're going to get better, that you need to get better, really made me feel that there was something wrong with me too, when, there really wasn't. So just those labels and the way people talk and the lack of education really stood out. And these were the people that I thought could help me. This is where I thought I should go for help, and for them to not be able to give me any answers that actually helped, it was really hopeless. It was frustrating. And it felt like there was nowhere to go. Like it felt like there was no point in even trying. So one time in particular, I remember I'd been in Ottawa, I had been on the streets, I'd been gone for months. I have no idea how long. I was sick, I was hurt, I was crying, I had abscesses and wounds all over my body. I had many needs that needed to be addressed healthcare wise. I went in to see her and I talked to the nurse, and then when she came in, she kind of looked me up and down. She talked about my drugs for a bit. We didn't take care of anything at all. And then she told me that she would pray for me, and that was the best that she could do for me. That was not what I needed to hear at the time. That was not what I needed to hear from a healthcare professional. I needed to do help. I needed my wounds cleaned. I needed the abscesses lanced. I needed, maybe somebody to talk about the trauma that I experienced that we talked about when I first came in. There was a lot of stuff that they could have done, and to be told, I'll pray for you, was just like crushing. Like it just... It makes it seem like there's no point in trying when that's the answers that you're met with.
Help is not available when stigma is prevalent.
It's one thing to say that somebody made a choice, but if you look back and look at what was happening, there's a lot of times that there were no other choices. That was the only thing that was available. And even still today, that's, if someone is keeping well, they're not making a choice to do drugs. They're just trying to survive. They're just trying to get through the day. They're not trying to commit a crime. They're not trying to be a drug user that's doing something bad. They're literally just trying to be okay so that they can survive the day. I ended up using again. I just continued on the path that I'd been on. There was no point in my mind to try to do anything different, because that was the same response I was going to be met with, and what's the point?
Jess is able to share her story because of a chance encounter with a community nurse who made the choice to help. Her name is Melinda. She's a nurse practitioner, and she wants to reduce the stigma in the healthcare system and change how we react to people who use substances.
One of the things that as healthcare providers we can choose to do is every single healthcare provider, in whatever the role they have, whether they're an emergency room nurse, whether they're assisting and doing pre-op in surgery and admitting someone, wherever they are, we have a voice that can advocate for each individual patient. And we can use our voice, whether it's speaking about our patients and the words that we choose to use, how we address people, how we treat the person we're with specifically, and caring for them and being kind, like you said. And even if you're having a bad day, be kind to that person, regardless. To how we write our notes, the words we use in our notes, because those words, that's my voice that someone else is going to read. So I can choose to say that this person is a drug addict, or I can choose to say that this is a person who uses substances, or this is a person with substance use disorder. Those are very different things, and that's me using my voice in my charting, regardless of what field I'm in, who I'm caring for. I have a voice when I need to consult with a surgeon who's going to be doing surgery, and I know that my patient is using OAT, to talk about pain control, to talk about managing post-operative pain. I can use my voice to talk about that and make sure we're prepared and make sure that they're being cared for in the healthcare system. So whether we are working as an RPN, an RN, whether we're physicians, nurse practitioners, physiotherapists, whoever we are, by using our voice and the words that we choose to speak and the words that we choose to write in our notes is how we can have an impact on our healthcare system as individuals, and hopefully collectively to improve the experience that individuals who use substances have in our healthcare system.
Healthcare providers have the choice to be a voice for individuals who use substances.
So I do think that it is a lot of people are starting to feel the pressure. You know, we have a municipal drug strategy now. We're doing a lived experience survey. So people are trying to counteract what they're seeing on there. But I think the reason that we've been stuck in this so long is that nobody is recognizing it as a problem, because nobody is being the voice of the substance users, and everybody is just okay with the way that we're treated. So I think we need to recognize that we are not being treated well. We are not receiving the same treatment that everybody else is receiving. Being okay with that, you know, it's not something that we're okay with, but being okay that it's an issue, and then recognizing that it's an issue that you need to change and being willing to change it. But I think right now a lot of people keep their head buried in the sand almost and pretend like it's not happening, or they believe that it's okay to continue to treat people like that because they're choosing to make that choice. They're choosing to live that way. They're choosing to wind up in our ER every couple of months. They're choosing to be homeless. And again, not true, not true, not true.
Help and hope leads to resilience.
What I'm amazed about with people is that there is resilience in people, but it's really hard to find your own inner resilience if you don't have the external support. And so that was an opportunity where your inner resilience and who you were as a person inside of you, and my opportunity in my role, and my passion for caring for people and meeting them where they're at, and leaving all of the history aside and just being with that person and caring for them as a person and nothing other than that. Those met and helped us on this path, and like you said, with many other providers and people involved. And that's where, if we as healthcare providers see people and just know that inside of them there's some resilience, and honestly in individuals who use substances there's a lot of inner resilience because that's how they're surviving. And if we can tap into that and be kind to them and care for them and meet them where they're at, then those two things together, I really believe, and that's why I've spent my career doing this, is what can help change the trajectory of someone's path.
Yeah, I love where I'm at now because I've had a ton of support. But what I do right now is peer support and try to, make sure the people that are still out there are using safely, have naloxone, have somebody to talk to, have somebody that's been there, have somebody that, knows everything about them and doesn't think they're a bad person. And so that's kind of what my role is. I work out of the OAT clinic downtown, sometimes out in the community. A lot of what I do too is connecting people with resources that they didn't even know were available, you know. Sometimes I'm testing people's dope for them to see what's in it, which I think is a great option and something that should be more widely available, especially right now, I mean, I just feel very privileged to be able to be part of these people's journeys and to have them trust me the way that they do and to have the relationships that I have. And you know, part of the reason that I do it is because when I was on the streets, there were people doing outreach that didn't judge me, you know, that cared about me, that would go out of their way to make sure that I was still around. And that made a huge, huge difference in me wanting to kind of take back control of my life. And that was something missing where I was at, and knew it was something that would help. So I'm very grateful that I have the opportunity to do that. Very, very grateful.
Today, we can choose to act. Today, we can choose to provide the best care we can. Today, we can begin to heal. Today, we can protect someone's tomorrow.
So what we would like you to do now is take some opportunity and take some time, 2 or 3 minutes, and do some self-reflection on here's a few questions that you might want to answer. What stood out most about Jess's story? And what roles did healthcare, social services, the justice system play in the trajectory of Jess's journey? Some of the other things that you might want to consider is the role of trauma and substance use disorder, why substance use disorder is not a choice, reflect on any internal bias that the video may have shared with yourself. So the Substance Use and Addictions Program grant. So the health unit was afforded the opportunity to apply and were awarded a 3-year funding grant through Health Canada. Unfortunately, we received this grant and found out about that we had been awarded this grant a month before the pandemic was declared. So we started working on this grant in 2020. We were really lucky in that we, as an agency and a community, were able to actually continue the work through the pandemic. Some of the other recipients across Canada were not as fortunate to be able to continue the work that they had been given the funding for. So with this grant, we actually were able to hire 2 part-time harm reduction community support navigators. These were people with lived or living experience. They were embedded in our OAT, or opioid agonist therapy clinics, here in Brockville, Smith Falls, and in Carleton Place. Their key areas of service which they focused on was working with people to provide harm reduction education and supply distribution, system navigation, health, social supports, and as well as the justice system, engaging in peer-to-peer engagement, and facilitating connections and referrals to other programs, other services in our community. The second component of this project over the 3 years was we wanted to explore the experience of people who use substances and accessing the services in our area in Leeds, Grenville, and Lanark, as well as what it was like their experience to be retained in service. That was one piece of it. The other piece that we wanted to explore was what it was like for service providers or frontline service providers in providing services to those who use substances in our community. So our community support navigators, Jess being one of them, spent about a year doing one-on-one interviews with people from all walks of life, all substance use experiences, and conducted individual interviews throughout the year with about 150 different people. We also had collected information online through a survey that was open to family and friends, but also people who use substances that weren't as comfortable and maybe didn't want to do a one-on-one interview with our peer workers. The other piece that we did was we conducted 5 service agency providers focus groups that were led by our peer support workers, Jess and Amanda. And we looked to analyze common themes from both sets of data that we collected. We have utilized those themes to help build this training. And this is the final deliverable of this project. So I just wanted to take a minute to acknowledge some of the key folks that helped us along our journey. This was a huge undertaking and a trying time during the pandemic. And I'd like to acknowledge the hard work of all of the folks on this slide, but especially people with lived and living experience. We would not have been able to do the work that we have done without their courage in agreeing to have these conversations. And sometimes they were really hard conversations, both for the folks that were participating in the survey, but also for our peer support workers who were conducting the interviews and taking in all kinds of information and personal stories of people's experiences. We also want to thank family and friends and supporters of people who use substances for participating in the survey. The community agencies that participated in the focus groups. We know that was, again, not an easy conversation to have and to have those open and honest dialogue about what's actually happening and how challenging at times it can be to serve people who use substances. I want to thank Jess Bashir and Amanda Watson, who were the 2 peer support workers that we were able to hire. They provided fantastic support to this community and have become very much an integral part of the success of our harm reduction program. Jennifer LaBelle, who is a PHN here at the health unit, who stepped in my absence while I was away. And also our QIS, who helped do all the analyzing, all those interviews, which was a lot of hard work and helped us to come up with the themes, and Change Healthcare for being a great ally and community partner in allowing us to embed those peer support workers into their agency to offer that support. And last but not least, our advisory committee. Without the expertise and knowledge of every single one of the folks that are on this list, this project would not have happened and would not have been as successful as it has turned out to be. So thank you to everybody. Jess, I will hand it over to you to kick us off and get us going with our stigma primer.
Great. Thanks, Jen. And just quickly, I just wanted to say what a privilege it was for me to get to capture the voices of my peers doing those surveys. A lot of the stuff they had to say was heartbreaking to hear, and I believe for them heartbreaking to talk about. But we both knew that this was going towards a good cause and would be used to make changes within the system. So it was great. It was awesome. So some of the voices of people who use substances in our district, we have some quotes here. Great, that's the withdrawal management service they're talking about. They both were pleasant and had my best interests at heart. All experiences, have had many, were terrible. Most staff were very ignorant, treated me poorly and as less than a person, been denied care because of being a drug user. So as you can see with the first slide, we had answers that were great and answers that were terrible. It ran the gamut there. It was not a good experience. The hospital staff judge me. I feel low and dirty. Leeds and Grenville area hospital, very rude, very insulting. They overlooked the problem I was there for, every time accused me of just drug seeking. Again, Lanark area hospital, first visit, same thing, but second trip, the doctor was accepting and treated me like gold. It was nice to hear.
And Jess, I know one of the quotes that really stood out to both of us, and it's not the first time that we've heard it, but the notion from people who use substances that they would rather die than go to a hospital. And I don't think it's just in our area, but just to go to the hospital in general, they're voicing concern that they would rather die than to seek medical care. And I think that was probably for a lot of us one of the hardest things to hear as healthcare providers ourselves, that this is something that our people within our community are feeling.
Yeah, it was a common theme. And I mean, we've seen it happen over and over and over again. So this is a really great video, Stigma, Social and Self, Individuals and Society. It's MCAT, the CAN Academy. And it is off of YouTube.
Yes, and we will cue this up momentarily.
Social stigma is the really extreme disapproval and discrediting of an individual by society. But actually stigma comes in two different forms. The first is social stigma, and the second is self-stigma. Now, when we mention social stigma, what are we talking about? Well, social stigma, it can be fueled or associated with several other key concepts, and these include stereotypes, prejudices, and discrimination. One of the challenges is that the degree of overlap between stereotypes, prejudices, and discrimination and stigma is not entirely clear and appears to be somewhat variable depending on the source. We commonly encounter social stigma when we are looking at conditions such as medical or mental health conditions or other issues such as sexual orientation or criminality. The stigma against mental health is a major challenge. So let's try and look at that a little bit more closely in this example. In this example, many individuals may believe that the mentally ill are violent. This is an example of a stereotype in that it involves a belief or a cognition that is generalized to a population. If this cognition subsequently leads on to a negative emotion or a negative affect being associated with it, then this then would be an example of a prejudice. In our example, if I start to become scared of the mentally ill, that would be a prejudice. Finally, if through stereotypes and prejudices we actually have a change in our behavior, this can lead to discrimination. A discriminatory behavior would be if we are scared of the mentally ill, we may not want to live close to them or, for example, hire them in our workplace. Social stigma and the components of social stigma can vary a great deal by the socio-political context, sexual orientation, for example. Now that we've mentioned social stigma, let us look at self-stigma. And one of the things that can happen with an individual is that they can really internalize all the negative stereotypes, prejudices, and discriminatory experiences that they have. As they internalize these negative stereotypes, prejudices, and discriminatory behaviors, they may feel rejected by society. They may feel like they need to avoid interacting with society. They may really struggle to come to grips with their condition. For example, someone who has HIV or AIDS and really feels the social stigma may go into denial and deny to themselves that they have the condition and not receive medical follow-up. They may also experience hits on their self-esteem or suffer from other mental health conditions such as depression. And then they themselves may display behaviors that really isolate them from society and stop them from even attempting to take part in education, vocation, thereby further isolating them. So it appears that not only is the stigma directed from society and other groups towards the individual is important, but also the stigma that's directed by the individual towards him or herself is also important. Let us also consider studying stigma by using these concentric circles. In the middle, I'm going to label the first circle as self, representing the individual who is stigmatized. The second circle shall represent the family or the close social group. The third circle shall represent wider society. And finally, the fourth circle shall represent things external to society, but that are very important, such as the media. One thing that we should appreciate is that there are bidirectional relationships between all of these groups, such as the self and the family, the self and society, the self and the media, and also in between all these groups, such as society and family, such as the media and society. So let's have a closer look at these groups as we peel off the concentric circles. Let's start by looking at the influence of the media. The media is a major source of stigma because it can have depictions of various conditions as being violent, dangerous, or representing moral failings, as is commonly the case when we encounter representations of mental illness in the media. But it can also be encountered in other conditions that are depicted in the media, such as HIV and AIDS, obesity, and people who have substance use problems. A useful intervention at this point is the development of guidelines for journalists to try and kind of decrease the amount of stigma that is present in the media. And there's several different sets of guidelines and suggestions in order to do this. And when we mention media, we know that social media is also a huge component. Now let's move on to society. Society is also very important because this is where the interactions between the self and society involve things like education, employment, healthcare. Stigmatizing views by employers, by healthcare providers, can really diminish the access of individuals to earning an income, to getting the appropriate level of healthcare, to even turning up for screening, getting follow-up. And an important intervention at this point is the use of legislation and anti-discrimination laws. Now let's consider the family. Now, the interesting thing here is that the family can not only be shunned by society if they have somebody with a stigmatizing condition, but the family may also shun the individual themselves. In this example, we may often see somebody in the family who has a stigmatizing condition to be hidden, kept away from the family, to really be isolated and almost kept as a secret within the family. So if we look at our concentric circles, the family can be stigmatized by society, but can also stigmatize the individual. So this also may be detrimental to personal or intimate relationships. So at this point, interventions such as therapy and education are also very important. Finally, we reach the very core of the structure, which is the individual with the condition, or the self. And in this case, we know that all these different interactions, media, society, and the family, the individual can internalize a lot of this different stigma, and that can lead to them avoiding situations, denying the existence of their condition, suffering from mental health conditions, and no longer really participating in society. Useful interventions at this point would be to educate the patient, to give them access to resources, support groups, and these resources will really help them to understand that they're not alone.
Here's a stigma primer. It begins with the labeling of differences and negative stereotyping of people, creating a separation between us and them. It can target different identities, characteristics, behaviors, practices, or health conditions. It can be seen both as a cause and effect. It continues to justify the devaluing of people through stereotypes and exclusion. And it happens in institutions, for example, healthcare organizations at all population level, example, norms and values, and through interpersonal relationships, an example of mistreatment and internally, self-worth and value. Stigma has 4 distinct components. The first being labeling somebody with a condition, and stereotyping people who have that condition creates a division, a superior us group and a devalued them group, resulting in a loss of status in the community. And finally, discriminating against someone on the basis of their labels. And that's from the Central Lynn Resource Manual from 2012. For discrimination, it's enacted stigma. It's a disregard for a person's rights, ostracism, loss of friends, sometimes rejection by family members. There's also loss of housing and employment. People can be dismissed or disregarded. And as we'll hear about today, they're receiving poor quality care.
And Jess, do you want to speak briefly about one of the things that we've noticed, that stigma and discrimination just doesn't happen within, say, healthcare to clients or healthcare or social services to the people that they're trying to serve. It's something that we also we see within the substance using population as well. And it's almost the hierarchy within that population. And I wanted you to speak to that.
Yeah, no, it definitely exists. We see it. I think there's a few different divisions happening. I think that there's people who haven't lost their employment or their housing, versus people that are unhoused, living on the streets, don't have a job. And then even within the community, how they're like the route that people use the drugs. So people that snort would perhaps look down on people who smoke or inject. People who snort and smoke would look down on people who inject. And it even goes backwards. So people that are injecting would look down on people who, to them, they would say like just smoke or just snort. So it's interesting how it happens both ways and throughout the community like that.
Mm-hmm. And do you want to speak, maybe you can share with us a couple of examples of stigma or discrimination that you've witnessed, maybe even during your time as providing peer support work through this project that you maybe witnessed firsthand or had maybe heard from clients that they had experienced?
Yeah, so definitely. And so if I think back to times that I would accompany people to the hospital to emerge, quite often like the stigma that I would see, like the staff would, as soon as they discover that this was a person who used substances, would immediately think that they were just either there drug seeking or there because they had nowhere else to go, or maybe looking for a sandwich. And really to think that somebody's going to the hospital drug seeking, I'm sure it does happen, but for most of us who use substances, we can get much, much better drugs out on the street than we can get in the hospital. So if we're going to the hospital, it's not because we're there seeking their drugs. Some of the discrimination that I've witnessed is refusing to actually admit people into the hospital or to get the doctor to come down to see them or to provide them any services.
And what about, I know housing in our community is a big challenge, and I'm wondering if you can speak to some of the discrimination or stigma that some of our clients and people are facing in our community.
Yeah, definitely. And you're right, it happens often. And even within like some of our agency housing, where you will have to have a worker for that agency actually present the person, like basically as a case, not as a person. And it seems that as soon as the fact that the person uses drugs comes out, that they're automatically like disqualified for the housing, which shouldn't be a right determined on whether you use substances or not. It's a basic human need. We all need housing.
Yeah, absolutely. And I think one of the other things, Jess, that we hear from our people who use substances quite regularly is the notion of not being wanted in the community and not feeling any sort of broader connection to the community in which they're living in. I think they have their own community within the substance using world, but they very much express on a regular basis of that feeling ostracized from the rest of the community, and that people don't want them, and I use that term very loosely, but want them here in their community. And I think that that's certainly something that is not that is not gone unseen by the people that are struggling in our community. And not even that, but oftentimes I think we see the ostracism from families, or that disconnection, the loss of friendships that are happening. And I think that that's definitely something that another theme that we heard loud and clear is that lack of connection outside of their own peer group. And that can be a real struggle for folks when we know that one of the biggest things that we can do for this population is to help them to feel connected within their community. And it's certainly something that we've seen quite regularly here is that they are not feeling connected to the community.
Yeah, no, you're right. A lot of people feel as though they're a burden, and that the isolation that this creates is really detrimental to people's well-being, like their mental health. It's not healthy at all. And really it was connection that allowed me to make changes in my life, and I would love to be able to provide that same connection and on the same level to everybody out there looking for it. We just don't have the stabbing power right now to do it, which is a shame.
Yeah.
So we do have some more quotes here from people who use substances in Lanark, Grenville, Leeds district. First one on this slide: I'm not wanted in this community. People just see me as a worthless burden. I'm a person just like them. There is no hope. So it speaks to exactly what we were just talking about. They, and I'm speaking about the withdrawal management service, see me for me, ask me about my day, my children. They want to see me for the person that is, not just the dope I'm doing. And to be worthy of housing, you can't be using substances. Housing is a luxury only for those who are clean or not using substances. So we have another stigma primer here. Stigma can benefit those in power in several ways. So the first way we have is by keeping people in. So that is by enforcing preferred social norms and values. By keeping people down, which maintains one's group advantage in society. and by keeping people away in order to avoid disease or a perceived threat.
And I think too, one of the things that stands out to me from an agency perspective is by keeping people down. So it's creating barriers and unnecessary challenges for people to jump hoops to get into service, or you know, some of the things that jump out at me is the collection of unnecessary information about people on our intake forms, on our history forms, and asking questions that are not pertinent to the care that you're going to be providing necessarily. And sometimes it's about making it very difficult for people to access services. One of the things that probably jumps out at me that is when accessing things like OW or ODSP, and where, you know, many of the folks that are accessing those types of services have low literacy skills, and they have disabilities and multiple different disabilities, yet we are asking them to fill in 40-page application packages, and sometimes they're expected to do that on their own with very little support, and so some of those things are ways in which we as agencies purposely, and not just agencies but the system, the broader system, create challenges and barriers to prevent people from necessarily accessing some of the services that maybe they would actually benefit from.
Yeah, I think another piece is like asking about people's trauma and not providing any aftercare or support after you have that conversation, and just kind of closing the door behind the person when you're done filling out whatever you needed to fill out. I think it leaves them pretty raw and vulnerable.
Absolutely. Yeah, one of the other things that I know it's a struggle in our community, and not just our community, but many communities, is the multiple doors to go through to get service. Agencies have core mandates and services that they provide, but oftentimes it takes a lot of courage and a lot of work for people to actually build up the strength and courage to come and grace some of our doors. And when that door may not be the right door that they are looking for, sometimes the door is just shut and no follow through or support, or that warm handoff is done at sometimes, and that can create further ostracism within our community. Or like Jess said, oftentimes if it's discovered that people use substances, the expectation that they stop using substance first before they can access some of our services, or maybe the behaviors that come along with substance use are not tolerated. And so things such as banning people for extended periods of time from agencies, and especially in small communities where we don't have alternatives to send people to, that becomes a huge barrier if we're talking about how do we connect people within the community and build that connection. And sometimes it's, you know, doing some self-reflection at our own agencies, looking at what are our processes? Are we creating environments where those kinds of behaviors that some people might find frightening or less palpable, are we creating some of those environments ourselves that enable that behavior to happen in those agencies? So just some of the things that we've learned out of some of our research that we've done over the last year.
Okay, so we have another stigma primer. Some of the ways stigma manifests itself for those experiencing mental health and or substance use issues include stigma by association. Some people choose not to be associated with someone with a mental health or substance use issue. Low self-worth is a very, very common one. Avoidance of treatment, poor quality of care when treatment is sought. Again, unfortunately, pretty common. decreased employment, housing, and educational opportunities. See a loss of friends and family members, a social and support network just kind of disappearing. And self-stigma, which is created when someone with a mental illness believes the negative messages that they are hearing and seeing. And this information was from Understanding Stigma from CAMH.
And one of the examples, I think, Jess, that we have probably seen kind of happen over the years, initially, one of the ones that jumps out at me was when we first brought on naloxone distribution in our community, and the importance of calling 911 in a naloxone response. And one of the barriers that we felt was going to hinder people calling was the fear of police in our community. And we've come to discover over the last 4 to 5 years of providing naloxone in our community and having conversations with people day in and day out about, what the overdose was like and what happened and those kinds of things. And what we've come to discover, that it's not really the fear of police that keeps people in our community from calling for medical help. The thing that we hear loud and clear is it's the treatment that they receive at some of our facilities, the hospitals, and that is actually what's driving people at this current moment to not seek care. And I think that that's something that's been, came out in our research, but it's also something that we've in conversation have learned, Jess, over the last few years. And we always just assumed, and because that's what we often do as other staff and people that work with this population, we have always assumed that it was the fear of police showing up. And that does not seem to be the case in our community, at least right now. And Jess,
the police have been great. We have the Good Samaritan law, but I think that they kind of go above and beyond and just turn a blind eye to stuff when they're on site for an overdose. And I have seen, countless times people that have had CPR performed on them for, upwards to 15 or even 20 minutes, not want to go to the hospital because they cannot face being treated the way that they are treated every time they go. Again, would rather die than seek care.
Yeah, and we've done a lot of work with our police and fire over the last few years. As a community, we've done a lot of work and had some tough conversations between us and the police. And I think that that's gone a long way to helping to break down some of those barriers. And I think too, something that's certainly helped is because the police are responding to more and more overdoses, their experience and their skill sets and have really not improved, that's not the right word, but they've really gained some confidence in how they're interacting with people who use substances, and that's come a long way in the last few years. So I think there's certainly some success stories in our community for sure, but there's I think the study and the research has definitely identified some areas where we could be still improving some of those services and interactions with people who use substances in our community.
Okay, we have another video for you guys to watch. It's the experience of stigma. So this video is called Stop Stigma, Save Lives, the Experience of Stigma, and the video was produced by Northern Health BC.
A lot of us struggle really hard. I just would like actually just to be heard, or to get to know me, or say you don't want to know me, that's fine, but don't look down upon me. You don't even know me.
Things that make me happy, not being discriminated. I just like being safe. It'd be really nice to have a place to go, place to live.
I feel judged like going into businesses or stores, you know, because I'm Native, they will follow me in the store. They automatically think that I'm going to steal, you know, just because of my color or my race. And because of the track marks on my arm, they automatically know that I'm an addict. So they think that I'm in there to steal, to support my habit. Yeah, I get that quite a lot wherever I go because of my appearance, I guess. It hurts. It hurts a lot.
Most of the time I feel like as an outcast, like a black sheep. Like, doesn't matter where I go. If I get clean stuff, I can't find a happy place where I fit in because I'm always looked at different. You know, I go into shopping centers, stuff like that. I get followed around. I'm kicked out of just about every store in town. Yeah, I get judged because I don't know why. I don't know why people judge me that way.
It was a horrible feeling, the way they made me feel. It made me feel like I was a germ. Yeah, I will never go back there again.
So I have a hard time going to the hospital now when I'm sick. Being looked and judged by somebody that's supposed to care for you and help you, it's, you know, it's really, really hard on a person.
Impact on me and anybody who uses illicit substances is that you're categorized into this, that you're identified then by your drug use or your drug of choice, not as a human being or who you are.
Just treat me like human, instead of just judging me by my appearance.
You'd be surprised, just talk to somebody on the street. If you see them and you think they're addicted or have them, don't shun them away. You'd be surprised who they were or what they did before. It could be anybody. I'm just as human as everybody else.
We have another quote from lived experience person. Hours are difficult for working people. Ideally, they'd operate more like a physio clinic, 7 to 5 and 7 to 7 a few days a week. Staggered lunches for staff would allow clients to access service on their lunch hour. Having to take time off of work is a huge deterrent to accessing services. Access is also poor. Having to wait weeks for an appointment is just not acceptable. Client leads have to be such that one can be seen in a reasonable amount of time, less than a week. 3 weeks later, the moment and the motivation has long passed. Quick, urgent access would be helpful. A few 15-minute slots daily, for example.
All very good suggestions, and it's certainly, I think, something as agencies we've struggled with over the years of how do we improve access to service and in our community. And I think in rural areas we struggle sometimes because we do have very limited service providers to begin with. And so, you know, something that we hear quite regularly is the wait times are a struggle. And especially in this population, when they, this group of folks, that when they decide that they are looking for help or maybe want to make a change, they are faced with these long waiting times, unfortunately. And that's not unique to this area, that's across the province and probably across the country as well. It's and especially as we come out of the pandemic, those wait times have definitely gotten longer. But it's how do we capitalize on that urgent access and getting people in the moment, as this quote said, and when the motivation is there. Because oftentimes we are talking about life and death for many of these folks. And as, I mean, Jess can certainly probably speak to it more, but that fleeting moment could be gone and gone forever for some of our very vulnerable folks that we serve.
Yeah, I see it all the time in the CDSU. We have people put referrals in, but by the time their bed date is coming up, they're no longer interested.
Or maybe no longer with us.
Yeah, there's like that saying, dying on a wait list. You know, there's been a lot of people who we've lost that have sat on wait lists.
Absolutely. So after that video, we like to, and after we've done some conversation about what is stigma, what is, you know, what leads to stigma, what can stigma look like for people? We wanted to have our audience take this time to do some self-reflection, 2 to 3 minutes, and think about how stigma does. We've talked a lot about some of the barriers that are created for people to access support with mental health and substance use. What does this stigma look like in healthcare and social service environments? We've shared a few examples of things that we've noticed and that we've observed, and we would hope and like you to reflect on maybe an instant where you witnessed stigma or discrimination play out, maybe even within your own agency, or maybe you're trying to help someone else access another agency and you came across some stigma or discrimination, or maybe even out in the community, the broader community. What are you seeing, excuse me, in Brockville, Leeds, Grenville, Lanark, Smiths Falls, any of the smaller areas? What does that look like?
We have another stigma primer for you. People living with concurrent mental health and substance use face increased stigma because of different perceptions, like people living with a mental health or addiction problem are dangerous, and that those with both problems are even more dangerous. People who misuse substances are lawbreakers and can't be accommodated in a mental health care setting. Addiction or substance use implies a lack of self-control. Using certain substances can increase a person's likelihood of contracting certain conditions such as HIV, AIDS, and hepatitis C. Care is often fragmented, which means that the treatments for mental health and addiction often take place in a different setting and with a different set of professionals who do not communicate with each other, which can be very frustrating for people. Service providers often lack the skills and feel helpless and sometimes hopeless when treating concurrent mental health and addiction issues.
And I think a couple of those probably stand out in what we're experiencing here in Leeds, Grenville and Lanark. I think the last bullet is something that we've observed over the last few years. And if we look back towards substance use pre-pandemic, and I mean, we were struggling to support people then, and now we fast forward 3 years through very challenging times with the pandemic and lack of access to service that was even greater than before. During that time frame, people are struggling. I think, Jess, you could probably attest to that as well. And what we're seeing now is the complexity of the situations that people are finding themselves in is making it even harder for service providers to be able to come up with in consultation with people, come up with solutions that are tangible solutions that we can actually make happen for people, or help them to make happen and meet their goals and come up with some success for them. I think the other thing that I think we definitely struggle with in our area at times is the separation of mental health and addiction services can be a bit of a struggle. And it may not be happening with malintent that happens, but it's certainly something that our clients and the people that we are serving have definitely been frustrated with over the years. And I think adding the pandemic on top of that has certainly escalated some of that in our area. But I don't think we're alone in that. I think that's something that many service providers and people who are using substances are struggling with across the province. Jess, is there anything that sticks out for you on this?
The piece about the fragmented care, I think, and going back to asking people to talk about their trauma, I quite often hear people talk about, and have experienced myself, even having to tell your story over and over and over and over and over again. And it's almost as if, you don't feel heard, you don't feel that you're important enough for people to communicate about. And it just becomes like this redundant piece where you're giving a piece of yourself over to this agency, this worker, and for why.
Mm-hmm. Absolutely. And I think too, oftentimes people who use substances and also have a mental health illness often report too that it's like having that double burden, I think. And I think that's a bit of a struggle. I think oftentimes those two go hand in hand, as we know, but they are concurrently, like debilitating. And sometimes, and I think in our case, we're seeing the collision of mental health, substance use, and homelessness happening in our community. And I think that is a triple burden for many of our folks that were really struggling in our community. And when they're reaching out for supports, are experiencing stigma and discrimination, is disheartening for them and frustrating, and they do lose hope very quickly. I think we hear that theme quite a bit oftentimes we try to suggest things, and I think many agencies probably experience this. We try to suggest, have you tried going to this agency? They offer this kind of support, or they have this service that you could access. And they get very frustrated that we're constantly sending them to so many different agencies. And then oftentimes they come out of that with very little or sometimes nothing to show for their effort, right? Of maybe getting there, reaching out, or Jess, I'm sure you see that quite frequently as well in your work.
Yeah, I mean, sometimes we even see people having stuff taken away from them, maybe something taken off their check because or having their children taken away from them, reaching out for help with their substance use.
Mm-hmm. So another opportunity, I think, to do some self-reflection and looking back on, like, was there a time when you felt that discrimination or stigma was impacting the ability of people maybe you were trying to serve, or maybe you have a personal connection to this, to accessing service? We know that there are so many people in our community, family and friends, that are impacted also by substance use in their caregiver roles or their supporter roles. Is there a time when you felt that you were faced with stigma and discrimination, and how did that make you feel when you did encounter that? What did you do about it? Did you do anything about it? Were you frozen? Sometimes that happens, right? You're so gobsmacked by what just happened, you don't know what to do. Or did you take a stand? Did you reach out? Did you question maybe something that was happening at a service agency? And how could things have been different? Do you think there was an opportunity for things to be different? One of the final things that I'll mention about stigma and discrimination, I think it's something that we in the rural communities, rural, remote, right across the province of Ontario face. And I think it's a challenge for us. We're a small community. People know everybody in our communities, which is an added layer when we're talking about stigma and discrimination. As many of you know and have probably experienced, you go to your local family health team or your local community health center, and there's people sitting in the waiting room who maybe you went to high school with them, maybe it's your auntie or a cousin or a friend or your friend's mother. And that adds an added layer of complexity to people reaching out for support. And I think that that's certainly something that we need to recognize is an added challenge in our rural communities, is how do we manage when everybody knows everybody in your community, and that is an added struggle especially for folks that are struggling, who may have involvement with the police or become those sort of well-known people within the community, right? So Jess, I'm sure that's something that you've probably witnessed too over the years, but I think it's just something that we need to recognize as an added layer of a challenge for our service providers.
Mm-hmm. And some people are really great with it. They have the ability to almost like disconnect their relationship from people, and other people are not so great at it. But it is a challenge on both ends, I believe.
Absolutely. It can very well prevent someone from accessing our service, right? If they know that their best friend from high school's mother works at the health unit, that might be enough that would prevent them from coming, because they don't know whether or not they can trust that their anonymity or that the reason why they're accessing would be held confidential or private. And even just the shame, maybe the shame, blame, self-guilt of what they're experiencing could prevent them from coming, if there might be someone that might recognize them there.
Yeah, especially I think in that instance, when it's somebody that you went to school with and you're on different sides of the counter, it can really throw somebody off.
Absolutely. Yeah. So I think we will move on to, we base this workshop from a document, and we'll share that document at the end, but it's a toolkit that's available to help. It's predominantly been made for healthcare providers, but it definitely is something that is transferable to other types of agencies. But it's called the Addressing Stigma in Healthcare Toolkit, produced by Public Health Agency of Canada. And it's really been able to conceptualize and make visuals the different ways in which stigma occurs. And the next model that we're going to show you, that we're going to lead into sort of the next segment of our presentation, is really looking at how intersecting stigmas exist within the community, and it talks about how those drivers, what that looks like, what the experience of those intersecting stigmas can happen. And what they're talking about when they mean intersecting stigmas is basically, often you will be very hard to find somebody that is experiencing one type of stigma. Oftentimes the folks in our community that are experiencing stigmas are marginalized and vulnerable people from multiple different ways. And so things that, again, we've been talking about mental health, stigmas related around mental health, intersecting with substance use stigmas, intersecting with homelessness stigmas, maybe the fear of contagion, so the fear of picking up something from somebody. Often substance use and bloodborne illnesses go hand in hand, unfortunately. And both of those bring different forms of stigma, which will intersect and will contribute and compound to the negative and poor health outcomes people may experience because of those two conditions that they have that are highly stigmatized. So this is a really great model that just helps us to kind of put those into perspective, and helps us to give us an opportunity to understand how those different things can impact to deliver and end up giving us poorer health outcomes. So the next one is looking at substance use in particular. And the nice thing is that in the actual toolkit, there is a couple of different examples for things like mental health. There's an example for HIV/AIDS. So that you can take this model and apply it to any form of condition, disability that would have stigma related to it, and walk through it. So this one is the substance use stigma. So we're looking at what the drivers of stigma are. So oftentimes, and this is just one example, but the belief that substance use is a reflection of poor willpower or a moral failure, very common stereotype about substance use, and that people are to blame for their condition. Belief that people who use substances are inherently dangerous or reckless, and the belief that substance use is not a real illness and people can just stop if they wanted to. So some of the intersecting stigmas that people who use substances often feel, again, we talked about mental health. We've talked about sexual health related stigmas. So that could be gender identity. It could be homophobia. It could be things like other health related stigmas. So HIV or hepatitis C stigmas. And so it's very rare that people are experiencing just one form of stigma in their lives. And some of the practices that happen because of these stigmas and stereotypes that come along with these conditions. So things like the negative portrayals in the media, the language in which we use to describe people who use substances, the denial of applications. I think Jess hit that one in one of her examples of having to present people as cases to see if they're eligible to access a service. Failure to accommodate people within our agencies who have substance use disorders. How many of our agencies right now have a policy on supporting people who use substances in our own agencies? I'm not sure how many of us could say that we do have something. Health systems we talked about the language. We'll talk a little bit more. Lack of empathy from professionals, or the lack of even motivation from professionals to help people meet their needs or what they're identifying. And then the experience. So the experience of stigma is the discrimination that people, so that's the enacted behavior of carrying out that. So things like internalization of stigma, the shame, we talked about that, the embarrassment, anticipated stigma or secondary stigma that they experience from their friends and family, the ostracism, the being banned from agencies, those kinds of things are all things that could be considered discrimination against people. Outcomes and impacts, we talked about that, decreased use of healthcare and social services, poor quality of services. They hide their substance use. They just won't tell you. It's safer for them not to disclose that information than it is for them to disclose that information to service providers. And we know it perpetuates further health harming coping behaviors. So one of the things that jumps out at me would be needle sharing. The stigma of people think that they're going to be judged for accessing needle syringe programs. Their alternative is to share equipment and spread bloodborne illness amongst themselves and maybe into the broader community as well, because many folks have partners that are not involved in the substance using world, and that's a risk that is definitely there. And we know that poor health outcomes. So now we're going to delve into exploring the drivers of stigma and the practices that happen. And I think one of the big ones that we continue to see driving stigma, and I think we've come we've made some strides, Jess, in this area for sure. We've definitely made some strides, but we certainly still have a long way to go in the language that we are using. And I think Melinda spoke really eloquently to it in the video at the very beginning. We, as service providers, need to take responsibility about the language that we use in our notes and our note taking and the words that we choose to use, because someone else is going to read those notes at some point. And it could very well be the client or the very person you're providing care for. And we need to be respectful of the language that we're using when we're describing subjectively and objectively the information that we're privy to. We know that the language that we sometimes use is inaccurate, further creates stereotypes. It's hurtful, and it's often dehumanizing and disempowering to people. The words that we communicate tell us what our assumptions are, what our values are, what our judgments are, and reinforce those negative portrayals of those that are devalued groups in our society. It actually shapes how people understand their world as well. And I think that's really important. The words that we choose to use when we're talking about people who use substances actually further shapes the world in which they understand where they fit in that world. So one of the examples is labeling someone who uses drugs as addicts or junkies marks them as less worthy of care and promotes fear. Describing illnesses ahead of the person, so not using person first language, so using words like they're a schizophrenic or they're a drug abuser or a drug user. It actually contributes to dismissive or demeaning behavior. It's again further creating that them versus us, and so using person first language is really important. These types of labels don't allow for other identities a person may have, and suggests that everyone within that group has the same wants, the same needs, and the same challenges, which is completely inaccurate. One of the things that I think and I talk about those of us who work in harm reduction in particular, we've tried to be very cognizant about not allowing people to describe themselves using those terms. It's one of the things that a colleague of ours who always leads off with, "Tell me who you are." And in that, I bet everybody can probably guess what the first words that many people who use substances come out with first. And almost every single time they lead with, "I'm a junkie" or "I'm an addict." And that is not something that this colleague allows them to continue to use. And she often, and pretty much every single time, will try and get them to reframe that, because people are so much more than their substance use. And so one of the things that we've found has probably been one of our most effective strategies in helping people with their substance use is helping them to see that they are so much more than what their substance use is. Because a lot of the times, and Jesse, you can speak to this too, is that they don't see themselves as anything but that, or that there's no hope that they could be anything more than that, or that, because that's what society tells them. And often, Jess, you can speak to the 12-step example that you have as well, but feel free to jump in.
Yeah, and I think having to identify yourself as an addict or an alcoholic and hearing other people do it, it literally strips away everything else about you, and you forget the person that you are. I'm still learning what I like to do and don't like to do. And I see it quite often in the concurrent disorder program right now, that identity that people have of being like the addict or the alcoholic, it's all encompassing. And I think it's a big barrier. I know it's a big barrier for a lot of people to make changes, because they don't know who they are without the substance use in their lives. They can't see themselves as anything other than somebody that uses or sells or hustles, or that's just their entire identity.
Yeah. Yeah, that's what I was gonna say. They can't see past the label of
Yeah.
themselves, and they think that they, I'm trying to think what the right word is that they think that that is what they have to call themselves, because that's what society tells them that they have to call themselves. And there's so much more to a lot of the folks that we are serving, like the talents and their mothers and fathers and children, and there's somebody's loved one. The talent, the musicians, the writers, all these things, right, is so much more important to highlight and to get people to speak to. That is so important. Oftentimes, in a lot of the work that we do in harm reduction, we actually don't talk a lot about the substance use itself, because that's all that they're seen as, is someone that uses substance. And so we try to help them see beyond that, and to really identify who they actually are beyond the substance use. And that's been really something that's been quite successful, that we've done in some of the work at the OAT therapy clinics. And I think that goes to the comment before, just they see me as a human, they see me as a person first. And they, not that we don't care about the substance use, because we care about it from a health perspective in the harms that the substance use can do, but we don't see that as the number one reason to be providing care for people.
No, and I think that stems from so many people see the substance use as the problem, when it's not the substance that's the problem. It's become the solution to all the problems. Problems are financial insecurity, food insecurity,
Relationship,
racism, homophobia. Yeah, exactly.
relationship
On and on and on.
breakdown.
Yeah.
Lots of different reasons. It's a symptom, it's a solution of a bigger problem that's happening. So we have another video also produced from Northern Health, BC. It's a fantastic video that talks, and it's made by people who use substance, and it's called Labels Stick and Labels Do Hurt. And I think, it's a nice reminder that we really do need to be cognizant of the language that we're using. And I think it's not about just the language that we're using when we're talking to clients or patients or the people that we serve. It's the everyday language that we use when we're talking to colleagues, or I think of one of the biggest ones is news, like the news and the media. And there's lots of community partners out there that do media relations, and being very cognizant of the language that we're using, or challenging the language that other people are using is a big piece of it too. And sort of our social responsibility as community agencies to advocate for the people that we're serving, that language is appropriate and not hurtful and harmful.
It's changed my life. No matter how hard I try to fight it and prove that I'm not using and try and make it better, it's just, there's always somebody to say, well, it's only a phase, or something. They really don't believe you, right? I've been clean for 18 months now. Still hard as ever to get going, because whether you're clean or not, it's still getting treated like you're still using. It's just hard the way things work that way.
Once you're an addict, it's posted like you don't stand a chance, really. Like I said, I've been clean I'm going on 4 years, and it doesn't matter. That doesn't get looked at. I'm already labeled drug addict.
It's like everybody's scared to be around me. They think they're gonna catch something from me, and it closed a lot of doors. And I'm still me. I'm still that guy that has got it in him to go out and slay fish and work hard and
people look at me as a junkie or a hoe or a drug addict or a drug dealer, dope dealer, whatever, you know, rather than Margaret. Like, they don't see me as Margaret, they see me as a drug addict.
But people don't see it, you know, they build up these stories or get these ideas in their head, and it's so hard to change somebody else's thought on how a person is when they're addicted. Even though I have an addiction, I like to be treated equally, just same as anybody.
Just don't give up. There's always hope.
So the next driver that we're going to talk about is implicit versus conscious bias. So implicit bias refers to the attitudes and stereotypes that occur unconsciously and inform our thinking and beliefs. Also behaviors about a certain particular group. These are not biases that we have really a lot of control over because they do happen below the level of consciousness. So things like assumptions are generally based on misperceptions or misinformation about certain groups. Like, for example, patients that have chronic pain may be denied medication on the assumption that they're purely displaying drug-seeking behavior. And that oftentimes is not a conscious bias of healthcare. It's something that's been perpetuated over many, many years and has just become part of the healthcare system. And it's not that it's taught anywhere that we should judge people that are coming about being drug seeking. It's something that's been ingrained over years and years of experience and those kinds of things that have happened. Whereas conscious bias is when an individual believes and then continues to reproduce the same negative stereotypes. So an example of that would be, so we've done so, if I bring it back to language, for example, so your agency has done language training, we've enacted policies on, we will always document using person first language, we will always speak in person first, yet staff continue to use language such as schizophrenic or this person is an alcoholic. That's a conscious bias because despite being educated, despite there being policies, procedures enacted, people continue to use that language that is leading to negative stereotypes. So I think another driver is a lack of respect and understanding for people's lives. So the lack of respect and understanding about the impacts of colonization and racialization, compounding impact of all the other social determinants of health. It's really that lack of acknowledging the impact of life circumstances and environment on people. And I think, oftentimes if we look at how we think of children and, we acknowledge poor environments in which children grow up in being impactful on, but the moment that they turn 18, we oftentimes forget about those traumas and maybe that environment in which they grew up in and the long-lasting impacts that has right through into adulthood. And sometimes still the environments in which people are being forced to live in because of income insecurity or food insecurity. And we don't recognize that as a compounding factor for why people are in the situations that they're in. And oftentimes, as healthcare providers in particular, we've been traditionally trained to focus on the individual and their lifestyle factors without acknowledging some of these other factors that are at play, such as the social determinants of health. I mean, I think we've gotten better over time to acknowledging those impacts, but it's certainly something that we still struggle with to really comprehend what those impacts are long term. And oftentimes patients, and not just in our survey, but in many different surveys and studies, have reported that lack of empathy and compassion from healthcare providers, and they feel blamed for their circumstances, while the systemic barriers that have contributed to those circumstances are completely ignored. Oftentimes, healthcare professionals fail to respect the diverse ways of knowing, which I think is really, really interesting. And I think of our Indigenous populations and the lack of respect and understanding at times we have for some of those more traditional ways of knowing or traditional ways of understanding what well-being means in their culture. And that certainly is not something that is well taught even today in many of our educational programs. Again, we have made huge leaps over the years. I think back to when I took my nursing bachelor's, it certainly was not part of the curriculum 20 some years ago, but I know it is now, but we've still got lots of improvement to make there as well. So another driver is the fear of danger and contagion. And we see this all the time, Jess, and I'm sure you can speak to this as well, is that often the fear that they're going to catch something from someone who uses substances, because we do know that one of the highest risk factors for having hepatitis C in particular is injection drug use. But there's definitely that fear of that you're going to catch something. And we often get that with when needles are found in the community. That's certainly something that I get a lot of phone calls about. And it, it's, well, the children are going to catch HIV from if they get a needle stick injury. And we do a lot of education around the actual scientific data says very much different, and that the risk is incredibly low, almost doesn't exist in that circumstance but there's that fear is out there, right? And so the other one that we get a lot of, Jess, and maybe you can speak to this, is that people who use substances are inherently dangerous or aggressive. And Jess, I wonder if you could share sort of your insights on that.
Yeah, and I think, between the two places I work, at the hospital and then at the OAT clinic, there's just day and night difference. At the clinic, I think the staff here know, like I certainly know that the clients that I work with would never harm me purposely. In fact, I think that for the most part, a lot of them would risk their life to make sure that we were okay if something dangerous did happen. However, at the hospital, I see, security being called right away as soon as somebody comes in that they have flagged as violent or dangerous. And that flagging system is such a big piece of it, and it just perpetuates the stigma. And it usually winds up making situations worse. People get, scared and defensive when they see the security coming. And the way they defend themselves is sometimes by, making themselves bigger or tougher. And that's just a survival technique. And a lot of people have learned that from living street life. And it's really not who they are. I think if we took the security out of the picture and treated people as people, that things would go a lot smoother.
And I think too, like one of the things that I know that in the agency that I work for, and it was a COVID measure to begin with, was the closing of our one of our sets of doors. And so thinking about again, the experience of some of our folks that have been through, I think in particular, have been incarcerated, and the limitation of movement within our agencies at times, that can be very triggering for people. There may be some trauma that they've experienced. And that's certainly one of the things that we came to realize very quickly once we were allowed to reopen some of our doors, was how impactful that has been on our program. And so just thinking of, again, sort of the barrier systems that we set up, or the, I think, again, like the security, those kinds of things. And we need to be thinking about what the patient's journey is like when they come and walk through some of our doors, and thinking about their other experiences that they've had, and could some of our practices be more triggering than they are helpful, even though we're trying to walk that fine line between safety of our staff, but also we need to think about the safety of our clients. And are we actually perpetuating higher incidents of things happening by trying to keep staff safe as well? So it's not an easy thing to determine where that balance is. But I think the more that we talk to our clients about their experiences, we can come to understand how the things that we do as agencies actually heighten situations rather than de-escalating situations. And again, I think of an example from a colleague of mine, and she's probably one of the best people that I've ever seen de-escalate a situation very quickly. Someone that's really having a bad day, as she likes to call it. Not even naming the behaviors that they're showing. They're just having a bad day. They're upset, they're not happy, and her approach is so taking into consideration the human factor. And her go-to always was, tell me the last time you ate, when was the last time you had something to drink, and when was the last time you went to the washroom inside. Those are her three go-tos. And anytime that I've been on site when she's done that, it de-escalates so quickly. And that's a community-based organization. So that wouldn't necessarily apply to all of our organizations. But again, it's thinking about, it's trying to humanize the person that's in front of you, and recognizing what their experience is, and knowing, okay, so this person is experiencing homelessness. I wonder when the last time they actually ate or had something to drink, or were even inside somewhere that was maybe safe for them, or when was the last time they slept, is really important. So just sort of some of those things that can certainly help decrease the fear of danger and that can sometimes happen.
And I think you can find a lot more information on how to do that just by looking up and becoming familiar with trauma-informed care.
Absolutely. Yeah. So one of the other driving factors that this toolkit talks about is stigmatizing organizational cultures. We know that organizational cultures influence whether stigmatizing practices are acceptable and how healthcare providers will interact with patients. And we know that the tone of an agency is set right from within, right from the top down, of what's acceptable, what practices are not going to be acceptable, how we treat the people that we're serving. And we know that also the stigma that's created within agencies can also have lasting impacts on the staff themselves. Because again, we don't know everybody's story. We don't know, maybe we have staff we likely do. I can probably guarantee you, if you're an agency on this call and learning about this, you have staff within your own organization that have children, that have maybe a spouse, that are struggling with substance use. And so when we are agencies that are creating further stigma and discrimination, that also is going to have an long-lasting impact on your own staff's mental health and well-being as well. We know that these kinds of practices and drivers do become embedded, and sometimes it's not intentional. that this happens, and it happens oftentimes over a long period of time. And it's reinforced not only by your clinical staff, but it's also reinforced, I think of, you have staff that are working your front reception and how important those people are to the experience of people coming into our agency, and what that is going to be, what it's gonna set the tone for the rest of the experience, right? We know that burnout and compassion fatigue of our providers, and we know we're all experiencing this, can further contribute to stigmatization and discrimination of people that are accessing our service, because people are tired, they're burnt out, they're frustrated, they're, we're seeing oftentimes the same clients and the same people over and over again. No, not a lot's changing. And that can be really stressful on our staff as well, to be trying to work within that kind of a culture as well. We know that there's imposing rules and policies that will shape the treatment of people, the recovery opportunities for people. One of the things, and again, the health unit, we certainly, we're on this journey just like everybody else is, and we have certainly done things over the years. And the one that jumps out to me is recently, the last few years, we had put up signs within our agency that had said no narcotics on board or on site. And, after much thought, consideration, self-reflection as an agency, we got to thinking, well, why would even anyone assume that we had narcotics on site? We're making an assumption about them, assuming that we have narcotics on site, when we have never historically ever been a site that would have narcotics. So why would we post a sign? And we're making a lot of assumption about the people that are walking in, again, that drug seeking behavior. And so we took the steps and we removed all the signage, and provided some education to our staff about why we were removing those signs, and understanding the self-reflection that has happened. And that's just recently, we just did that in the last couple of weeks. So I mean, we're all on this journey of making change and trying to improve the environments in which people are coming into, so that it's a safe and friendly, welcoming environment. So how does stigma lead to adverse health outcomes? So this again is from the toolkit. It's just a nice map. It kind of summarizes everything that we've already talked about, and a lot of the things that we already know about stigma. But we do know that the individual experience with stigma, whether it's enacted, so they're experiencing behaviors of stigma and discrimination, they're internalizing that stigma, or maybe they're even anticipating that I'm going to walk through those doors to that agency and I'm going to be treated poorly because I look like someone that uses substances. I'm already well known in the community as somebody that might use substances. So we already know that that automatically leads to three things: reduced access to protective resources, so things that will actually help improve their quality of life, improve their situation. It causes chronic stress for individuals who are experiencing that. And oftentimes it leads to violence and assault of people. So again, we already know that when we reduce people's protective factors, protective resources automatically have poor living conditions. They have a lower socioeconomic status, decreased access to and to quality of healthcare services. And those all lead to poor mental health outcomes and poor physical health outcomes. And I think that we see that, Jess, on a regular basis, right? I think of, of physical health, like the amount of physical health that goes untreated in this population of people who use substances is quite high. And I think there's a misconception too, Jess, about how people who use substances don't care about their health.
Yeah, that's not true at all. I think quite often it's either they've experienced stigma and or discrimination before, or seen it in their peers, or they feel like they are a burden and don't deserve that equal treatment.
Mm-hmm. And I think, we've seen people who have continued to use active substances and get treated for things like hepatitis C and do wonderfully and complete the treatment and become hep C free. We've seen, we've been able to work with a few community partners over the years to bring primary health care to people who use substances, and the uptake of clients that are interested in things like getting their immunizations up to date, understanding their sexual health better and getting treated and tested for things, taking care of their teeth. I'm trying to think of some of the other things, but lots, like getting a pap smear. How many times do we ask about, or do we get asked about, I'm overdue for a pap, and where can I go and get that done, and those kinds of things. So I think it is a big misconception that people who use substances don't care about their physical health. They may not be able to attain some of that primary health care in a traditional sense of how our systems are set up right now, but it's not that they don't want to. It's because accessing service is challenging for them. And so when we've flipped that on its head and brought the services to people where they're at, and it might even be on the street, they've actually participated in many of those primary health care initiatives. Jess, do you want to talk to how do we build resilience?
Yeah, of course. So a big piece of it is invalidating the negative beliefs, which if you're somebody that's been experiencing stigma and discrimination, that's nearly impossible to do on your own, because you've just internalized and you've come to believe all the stuff that you've heard. And that's where we need to step in and tell them that they are a person deserving of care and love and service, and just like give them that unconditional support. Attributing prejudices to ignorance, and I think by educating people, we can make a difference there. Drawing on their identities or social roles, which again, difficult to do right off the get-go. That takes a little bit of support. Educating others, I just mentioned, and the community culture and connection, because that connection to your community piece is so huge. And the culture piece also, especially in Indigenous culture, very, very big. By collectively changing the system, which we can do by engaging in collective responses and self-determination, by calling for meaningful representation, and utilizing a strengths-based and resilience approach instead of a risk-based perspective.
And I wonder too, Jess, if you talked a little bit about the meaningful representation, because I know this is certainly something that many agencies have struggled to do. And I think probably even more so with folks that use substances, and what does that look like, and how, I know maybe how could we go about doing that?
Yeah, so I mean, listening to the voices of the people that you're serving, and whether that's through some sort of survey, kind of like what we did, or by having a lived experience advisory group, which we see a lot in other communities, and hopefully we'll have that here soon. One of the things I would love to see in our community is kind of like a coalition, for lack of a better word, of people who have lived and living experience with substance use, where they can use their voice collectively to let people know what they need, and what their experience, what they need to be changed. But they need to have a safe space to do that in. And that in itself is a big task to come up with.
Yeah, absolutely. And I think too, we need service providers who are willing to lean into those, because oftentimes we're going to hear a lot of things that we don't necessarily want to hear, right? And it's not, again, it's not about placing blame or placing shame or calling out individual agencies. It's about committing to do better, and that we are not the experts in what people who are accessing services need. We can build on what they're telling us, what they need, but it's really, I think, coming in with an open mind and an open heart, and that's a challenge for agencies, right? Because it's how do we take constructive criticism and constructive feedback about the work that we are maybe so passionate about providing, but I think that that's, you know, something that as agencies we need to come to a better way of knowing how to do that, and a better way of, you know, taking in that information. And it's not a reflection on the individual staff. It's the systemic piece. It's the, you know, and oftentimes we don't know the barriers that we're creating because it's just always how we've done things, right? And so being open and listening and truly being open to that listening is a big piece of it, and not necessarily having to fix it right away. I think HS, because there's that notion too, sometimes we feel like we need to jump at it and fix it.
Yep, definitely. And it's not a band-aid solution sort of thing.
Yeah. So one final reflection, self-reflection, before we move into the action framework. So can you think of a stigmatized population? So we're thinking about resiliency. Can you think about a stigmatized population that have been able to resist, or who are working to overcome some impacts of stigma? How have they done this? And who are they doing this with? Like, who are the ones that are doing the work? How are they doing it? Maybe some strategies, maybe things you've noticed, how certain populations have been able to come together to overcome stigma. And how did they do that? All right, so our very last piece of it. So again, in this the addressing stigma in healthcare, there's this wonderful framework that we can work from that really will help guide some of those meaningful conversations and meaningful brainstorming of maybe interventions that we can do. And we want to look at it from 4 distinct levels of interventions. So the individual level, so how can we best support individuals? Again, if we think of building resiliency and those kinds of things, how can we best do that? At the institutional level or the agency level, what are some of the things that we can do as interventions that will help reduce stigma and discrimination at that level? And then, of course, at the population level. So we're going to look at each of those, and you'll have time to brainstorm some ideas of interventions that you've thought about as we've gone through this workshop, of maybe things that you're doing well within your own agency right now, you think, or are there things that maybe you'd like to see brought in, or different ways of doing things that maybe you've read about or you've heard other agencies doing, those kinds of things. So if we look at the individual and the interpersonal, so interpersonal could be staff to staff, it could be families and friends, supporters of people who use substances, those kinds of folks. So we want to look at it, interventions at 2 different levels, or 2 different types of interventions. So how will we help people to strengthen their resiliency? So things like, how do we change that internalization of stigma that people do, and take the information that they're hearing about people who use substances and take that internally? Improve their coping skills. What are some of the interventions that we can do to help people improve their coping skills, create supportive and empowering environments, and how do we help them build social networks, maybe social supports? And think of things like, things like meaningful engagement with people, advisory committees, those kinds of things. Like, how can we do that? The other piece is, how do we build awareness and change attitudes? And I think that interpersonal work, one of the things that, how do we as healthcare providers or social services, or just colleague to colleague, how do we challenge this negative stereotypes that we might hear in our office conversation that's happening? Or, people telling jokes about people who use substances, or it could be any stigmatized population. But so those are some of those things that we would like you to kind of brainstorm some interventions on. So the next one, we're going to go up another level. So institutional interventions. So think of your broad agency, or maybe agency to agency. So how do we address, so there's 3 areas where we like to come up with some interventions. How, as an agency or an organization, do you address things like biases? How do you address implicit bias and conscious bias? So again, we think of conscious bias, you know, how do we address ongoing use of derogatory language or inappropriate language in our workplaces? How do we build cultural competency to cultural safety? So focusing on individual training, knowledge translation, evolving to focus more on institutional change. And what does that look like? Because we have lots of staff that have gone and done trauma-informed care or have done cultural safety workshops, but how do we bring that to an agency level where that's the expectation of your agency? And then how do we hold institutions accountable? So ensuring that stigma reduction is a part and is weaved through agencies from an accountability framework, but maybe a strategic planning framework as well. So how do we build that into it? So take some time, do some brainstorming. And lastly, at the population level. So two things that really stand out in the framework is, how do we change the social norms? How do we work with our local media when we see headlines such as, the one that jumps out to me, that drug users use CERB money to buy drugs? Like, how do we as agencies hold and work together to change those sort of ongoing negative stereotypes about people who use substances? Look at policy reform at the national, provincial level. How do we advocate as agencies to do that work? Curriculum. I think of, the mental health and addictions curriculum in our schools. And, I have children that are just taking that information now, and how outdated some of that information is, and how it still leans on that moral misgiving and the lack of willpower, and how do we work with school boards to change that curriculum? Or even, how do we work with our colleges to change some of the curriculum that might be out of date or not reflecting best practice that's out there right now? And then the rights and protections of all. How do we advocate for laws and policies that will reinforce and uphold human rights? So things like housing, access to healthcare, the decriminalization, those kinds of broad level laws that have huge impacts on people who use substances. So take a few minutes and do some brainstorming. Jess, I'll hand this back over to you.
Awesome, thanks, Jen. So just have a few more quotes here from the survey. The first one is, I am a client and it's at one of the withdrawal management services. They're amazing, treat me with respect and dignity, bend over backwards to meet any needs I have, and always make sure I'm fed well. Staff friendliness goes a long way. Feeling like they're about you as a person rather than a number is good also. And the last one here, I wish a lot of these services could be call or walk-in and connect. Like no matter who picks up the phone and greets me in the lobby, they are who can help me instead of taking a message or needing to register and come back, etc. So again, the every door piece. For developing anti-stigma interventions. So we have the core principles for developing anti-stigma interventions. The first one is that it's to be driven by collaboration between health system leaders and people with lived experience of stigma. Needs to be designed based on research, evidence, diverse ways of knowing, and experiential knowledge. The third one is it needs to be multi-level with particular attention to multi-level initiatives that prioritize institutional and or population level interventions to address systemic stigma and discrimination in health systems. And I think, again, piece that's so important here is that needs to come from the top. If you don't have your leadership on board, it's not going to work. The fourth one is that it needs to be guided by approaches such as cultural safety and trauma and violence informed practice. It needs to attend to intersectionality, including the strengths, resources, and solidarity within communities who experience stigma. And finally, it needs to be grounded in principles of intervention research and implementation science to advance knowledge in the field. But all stuff we've mentioned.
Yeah, absolutely. And I was just thinking number 5, like how can we leverage the experience of those other groups that we hope maybe you highlighted in one of the self-reflections early on? How can we leverage the lessons learned, or maybe there's support in how we address stigma for people who continue to be stigmatized, right? So thinking about HIV and AIDS movement and the indigenous movement of reducing the stigma and how they've been able to advocate for themselves, and are there lessons learned through them that they could share, or maybe work with us on how to address some of these other stigmas that are happening.
So this is the Stigma Ends With Me commitment or pledge. And what we're doing is asking that each of you make commitment to take at least one thing that you've learned today and turn it into a next step action. Write it down using the Stigma Ends With Me page. It'd be awesome if you could take a picture of yourself holding the page or have somebody else help you with that and send us your photo. We will obviously request permission to use it on future anti-stigma campaigns. You can send it to Jen, her email is right there. And are you open to us following up with you in 3 months' time to see how your commitment's going? And just kind of, I think knowing that that's going to happen will help you kind of keep a fire going.
It's a means of accountability, right? Like I know, you know, the health unit, we're taking steps and recognize that we are also role models as an agency, and we've committed, you know, 3 years of work to this project, but the work's not done, and we're only just beginning ourselves to explore what stigma looks like in our own agency. And I think that this is a nice way for us as agencies to hold each other accountable, that we're all in the same journey. We're all trying to figure it out, and how can we support each other to do that.
Right, and that we can all be leaders, I think, in this journey.
Absolutely.
So what's next? The SUAP grant, the Substance Use and Addictions Prevention Grant. People with lived or living experience using substances, the 2021 survey summary report.
So those will be they're posted on our website now.
Awesome.
Yeah, so people will have access to those. Both of those reports are posted, and you're welcome to read. We highly encourage you to read those. We will be sending out a copy of those just to all of the participating focus group agencies that participated. They will be receiving the unedited version of those reports, so that they have the information that's not de-identified. These reports that are available to the general public are de-identified reports, but look at the themes that came out of the research study.
Right, because again, not trying to shame or blame anybody, just trying to do better all around. There's the substance use and stigma assessment tool, which the link will be, I mean, it's right here, but will be provided, right, Jen?
Yep.
And same with language matters and the equipped healthcare. There's also a bunch of training opportunities online. A couple of them we have here is the Stigma Ends With Me. That was a CAPSA who they're based out of Ottawa, and it's people with living experience, many of them providing peer support. The CAMH Understanding Stigma, which we've mentioned, quoted a few times today, and the Mental Health Commission of Canada's Opening Minds.
So that completes our workshop, and we welcome and thank you everybody for participating. We hope that this has and will start a conversation within your own agency as it has within ours. We really appreciate the time that everybody has put into this workshop and the research and this project. And we as an agency are committing not to let this just sit on a shelf somewhere. This work is going to be ongoing. It's going to be tough and it's going to be hard work, but it's necessary work that needs to happen to help support people in our community who are really struggling. We welcome questions. You can reach out to myself or of course Jess as well, but please, if you have questions, you want more information on stigma, we don't claim to be experts in stigma and discrimination, as we are too on this journey of discovery and personal and professional growth. But I think this is a great opportunity for us to work collaboratively and collectively as Leeds, Grenville and Lanark agencies to move this conversation forward. So thank you.